When a patient first hears that word cancer, the very next question is always the same. How bad is it? And for doctors, answering that question, well, it's like a meticulous detective story. So today, we're going to follow the clues in a real-world case to understand the critical steps of staging gastric cancer.
So, let's meet our patient. She's a 60-year-old woman, and right now she's really just a collection of symptoms. The very first clues in a high-stakes medical mystery that her doctors need to solve, and they need to solve it fast.
Her story started with things that, honestly, are pretty easy to dismiss. A couple of months of some vague pain in her belly, a little weight loss. But then the test started to reveal something way more serious. A CT scan showed thickening in her stomach, and an endoscopy confirmed it. There was a mass. The biopsy? That delivered the final verdict. Adenocarcinoma, a common form of stomach cancer.
Okay, the diagnosis is in. It's cancer. And now comes the single most important question, the one that's going to define her entire treatment journey from here on out. What do we do next?
Well, before doctors can even think about treating that tumor in the stomach, they have to zoom way out. The first, most urgent priority is to get the big picture. And that means answering one question. Has the cancer spread to distant parts of the body?
And this brings us to the official staging pathway. It's a really logical four-step process that guides every single decision. It all kicks off with step 1, ruling out what's known as metastasis, or distant disease, because you just can't plan the local battle until you know if the war is already spread.
To figure this out, doctors do a complete physical exam and a whole battery of scans, a CT of the chest, abdomen, and pelvis, plus a PET scan. And for our patient, this is where we get some good news. The scans come back negative. No signs of cancer in her liver, her lungs, or any other distant organs. Phew!
So, with distant disease ruled out, the investigation can finally zoom back in. The focus shifts from the whole body to the stomach itself. Now it's time to get a really high-definition look at the local tumor.
So what's the specific tool for this local investigation? Well, it's the endoscopic ultrasound, or EUS for short. This procedure is the absolute key to the next, much more detailed phase of staging. So why EUS? It's because it's the best tool we have for what's called T and N staging. This is the system doctors use to precisely measure two critical things. First, how deep the tumor has grown into the stomach wall, that's the T stage, and second, whether it's escaped into the nearby lymph nodes, that's the N stage.
Let's just break this down real quick. The T for tumor stage tells you about depth. How far has this thing invaded the stomach wall itself? The N for node stage is about breadth. Has it escaped into the nearby lymph nodes, which are kind of like the body's highways? Getting both of these right is absolutely crucial.
All right, so the team now has a pretty good picture from the outside with the CT and PET scans, and from the inside with the EUS. But there's still one more place cancer can hide, a place where even our best imaging can't see it. This calls for one final check, for an invisible threat. To find these hidden threats, doctors have to go beyond the scans. They perform what's called a diagnostic laparoscopy. It's a minimally invasive procedure where they put a camera directly inside the abdomen. It is the only way to see with their own eyes what the scans might have missed.
And this number right here is exactly why that final check is non-negotiable. In nearly 1 out of every 3 patients with a tumor that's even just slightly broken through the stomach wall, scans will look totally clean, but cancer will be silently spreading throughout the abdomen. A staggering 30% chance of hidden disease that imaging just can't see. The medical term for this is radiologically occult peritoneal disease, which is really just a fancy way of saying hidden from scans. And finding it, that's the difference between a potentially curative surgery and going down a completely wrong treatment path. It is that important.
Okay, so the full investigation is complete. All the clues have been gathered. Now, and only now, can the medical team put it all together and move from staging to strategy. It's time to choose the right treatment path for this specific patient.
And all that detective work leads right to this moment, the treatment plan, where the stage directly dictates the path forward. If it's very early stage cancer, the patient goes straight to surgery. If it's more advanced, chemotherapy comes first to shrink the tumor. And for those cases in the middle, it takes a full team discussion. You see, the staging isn't just a label, it's the actual roadmap.
And just one final but really important point. You might be wondering, hey, what about MRIs?
Well, in the specific workup for gastric cancer, an MRI of the abdomen just isn't part of the standard pathway. That combination of CT, PET, EUS, and laparoscopy gives the team all the information they need.
So, we followed the clues from a vague symptom all the way to a precise treatment plan. This whole rigorous process answers the most important question of all. How do you make sure every single patient gets the exact right treatment at the exact right time? You do it by leaving nothing to chance. It's the difference between guessing and knowing.